And now we have time for Q&A from the audience. We may have some questions from our online audience as well. But please, if you have a question for any of our panelists, please step up to one of the microphones on either end of the room. Questions?
I have one.
Yes. Oh, when you please tell us your name and where you're from as you ask your question.
Sure. My name is Sarah Downer. I'm from the Center for Health Law and Policy Innovation at Harvard Law School. So my question to all of you is, one of the toughest nuts to crack, in my opinion, is, changing provider culture. I think you all spoke really powerfully to that today. And can you talk a little bit about what else you think needs to happen to do that work?
Marshall, do you want to start? I think you addressed this a bit.
Yeah, that's a great question. It's a great question, Sarah. I'll mention two things. So people talk about cultural competency training, health disparities training. There's a big difference between courses that may teach knowledge versus courses that the end goal is having people be committed to achieving health equity. The best courses I've seen are very interactional and experiential. It has to involve relating to people's own personal experiences, in-depth discussions, having those tough discussions. So for example, like the course at the University of Chicago for first-year students is a required disparities course. They increasingly have cut down on lecture, have more small group discussion, direct contact in terms of like diverse patient populations and communities. There's a exercise where they do a project in the community, so it becomes real as opposed to and relevant and directly experiential. The second thing I would mention is a point that Ed made about like systems matter. And so you could have wonderful individuals who are all committed, but they work in a system that's not supportive. It just kills the life out of you. And so that whole point then about like how do we make systems better able to address disparities, to support the clinicians and patients in a tailored way. And part of that also is the financing in terms of having it all go. So really it's multi-level and all necessary for it to really work.
Did anyone else want to comment?
I would just add that people are motivated by feeling relevant. People know that the drivers of health and well-being do not tend to be addressed by most of the interventions that they're being channeled into providing. And the more we can allow people to address the fundamental drivers of disparities, the fundamental drivers of health, by supporting them, by providing them with resources and knowledge, by holding them accountable to those and holding the systems accountable to. In AIDS care, we're held accountable to viral load. The federal government ends the care continuum of what we're evaluating EDFA for on virus, as if people are viruses. People are not viruses. And so in a policy example of how to motivate relevance in HIV care or in serious illness care is to hold us accountable for depression, substance use, quality of life, and other metrics that actually patients care about and what are hurting and killing patients, and then resourcing us to actually address those factors.
Thank you. We'll move to the other side of the room.
Great, thank you. Alice Chen from the San Francisco Health Network, and just wanted to start by thanking Peggy and Bridget for grounding this conversation in the patient experience, Marshall for raising the issue of power, which is oftentimes not talked about, Kimberly for this idea of whole person care, which I think is also a really important lens. My question is actually prompted by Eddie's presentation, but would be interested in any of your thoughts, which is, as Marshall mentioned, screening for health-related social needs is kind of all the rage now in healthcare. In California, we're also talking about ACEs. We have a new Surgeon General. We actually are really excited about this idea of actually screening for ACEs. The question becomes what you do about them. And so, Eddie, what struck me about your clinic is that you focus less on screening and more on building the capacity before kind of unearthing. It was kind of almost a backward engineering. What we're talking about now is really universal screening. And then again, what I'm worried about is it may then create that trauma-inducing atmosphere among the clinicians and staff being really overwhelmed by what do we do with this. So would love to hear your thoughts about how do we actually both unearth the issue, but at the same time make sure that people aren't overwhelmed, both on the clinical side and patient side.
There's so much to speak about it. And I'll just say in terms of screening, in certain populations of people, it makes no sense to screen. It's unnecessary to screen to determine that this population of people have a high burden of trauma. So if you're working in substance use, mental illness, obesity clinics, HIV clinics, and many frontline poverty health clinics, you can predict that these individuals have a very high level, high burden of trauma. So screening for ACEs has other reasons, but one of the reasons in the general population people advocate for it is to awaken the people in that clinic to the high burden of trauma, so that even before you get to interventions and what you're going to do about it, it awakens them to the fact that trauma may be a key factor that is contributing to so much illness, so much chaos. And helps people demystify why people act the way they do, why they might be so reactive, why they might fade away in the waiting room and not say anything. And it breeds more compassion in patients. One thing I would say about ACEs and screening, people, just like early in the HIV epidemic, are terrified to open this can of worms about trauma. But there's nothing to do if people reveal an adverse childhood experience, or if even very intense histories of trauma. There are things to do if people are imminently facing danger or are suicidal. But when people reveal a history of trauma to you, if they do so organically or if you ask them about it, a simple statement of empathy, an appreciation for them being able to share such an intimate detail with you, and an acknowledgement that may help guide some of the treatments that we have to offer them.
It's a fantastic question, Alice. I'd point out one point that I think has been a theme throughout, I think, all four of our talks, that the need for partnerships. And almost like implicit in your talk was the sense that, well, when a problem is found in the healthcare system, it's the healthcare system and healthcare provider that needs to solve the problem. We certainly have our part to do, and we need more training in things like trauma-informed care. But a lot of these solutions will ultimately require expertise that we will hopefully get some baseline level of expertise in some of these sort of non-traditional health areas. But the true experts are going to be the people outside of healthcare. So, for example, housing. I mean, a lot of interest now in, compartment housing. One of the fears, though, I think like the social service sectors have, is that the money is in healthcare. This is fear that, the healthcare sector is going to basically try to take over in terms of, housing is role within health. And so I think we do need to think of something where we do have a comprehensive view, we know our part to play, and then we effectively partner with people that, frankly, are the experts in their particular area that is going to be that combination. So I think it's a delicate balance between responsibilities, you're saying. I think, of course, the whole clinician creed is we're responsible for our patients. Yet we need to create the systems and partnerships so that we can succeed, and that we also don't sort of go beyond what is our particular expertise. Yeah.
Marshall, I'm so glad you mentioned housing, because I was sitting here thinking, how do we make sense of social determinants of health and trauma-informed care that almost seem like separate issues, but really they're very intertwined. And so I wonder if any of you could talk about the relationship that you see between social determinants of health and trauma-informed care, and why do we talk about them as separate things?
Money.
Yeah.
When you talk about the two differences, one, the healthcare system, hospitals and clinics, they're looking at the bottom line. It's a business. We need to make sure that we are meeting our numbers, that we're not spending too much time on one particular patient, because that means it's going to affect the clinic or the hospital financially. On the other end with the patients, they're looking at the fact that they are facing a shutoff notice. Are they going to buy food, or are they going to buy their medicine? Are they going to continue their treatment? They're dealing with a doctor that they feel like they have racial barriers. The front desk person isn't nice to me. I'm dealing with my own individual issues. My aunt or uncle just got killed by the police. So there's a whole lot of issues that are happening. We've real life issues. We've got some women that have been part of Sierra Sisters ended up homeless because their jobs fired them because they were diagnosed with cancer. So the issues are great. When you have individual organizations like Sierra Sisters who are really in the trenches with the patients, they're trying to make aware in the healthcare system and dealing with social workers that sometimes will not do the social work on these individuals. They will give them maybe small information, but they won't give them all the information so that they can be relevant and be made whole as individuals. So the problem is deeper than coming together and saying, these are what the issues are. The issues are so deep and ingrained that we're not understanding how torn apart the families are. And even at end of life, they're being disrespected. We may put a nice bow on it, but truly some of the issues that are happening even at end of life are that they're being disrespected. They're not giving the pain medication that they need. And so then we step in and have to advocate for them. And I'm sure that our organization aren't the only one that's doing it because we're in Seattle. That is happening across the board. But how can we pull the clinicians and those people that are supposed to be on the front line to help the individuals and help our communities to become whole?
One thing that we found in trauma-informed care is that it can be a very helpful lattice fabric to connect many seemingly disparate efforts in our healthcare system. There's efforts to address high-cost, high-need patients, complex care, the integration of behavioral health into physical health, substance use treatment, trauma-informed care. There's roots in trauma in most of those conditions, and trauma-informed care can help provide a perspective and a number of evidence-based interventions to help address each of those without them seeming like fragmented checkboxes and separate interventions, but instead part of a whole.
And I'll throw it back to you, Peggy, that in some ways this is a great role for the roundtable to do this type of integration. I think part of the issue is just knowledge and education. So, for example, I personally need to learn more about trauma-informed care. I know probably more about social service health than trauma-informed care. And just hearing Ed's talk, this motivated to learn more about it. So part of it's probably knowledge on everyone's part. Second is that we tend to come in from our own perspectives or disciplines or what is the thing if you have a hammer, you hammer. And so I think it was wonderful how you assembled like the 4 different perspectives here from this panel. And that's something that that Roundtable is uniquely able to do to basically push people beyond their boundaries and just make sure people see, well, the reality is it is this comprehensive picture. It's just something like trauma-informed care and like the social terms of health. It's not an artificial distinction, so you can play a major role in helping to break down that artificiality.
Right, and think about solutions that work. Right. Mm-hmm. Okay, Christian.
Yes, Christian Sinclair, University of Kansas, representing the American Academy of Hospice and Palliative Medicine. As a palliative medicine doctor, I feel like I see just the end effects of lack of access to care, social determinants of health, and so I feel like my ability to change for a population is I'm impotent. My power is just not there. I can try and help that one person by advocating to their oncologist and to the health system, but what is the role for hospice and palliative care to really be advocates for larger populations to say, before they get to us already beat up, we want to help them earlier on. So I guess I struggle in seeing the effects, but not being able to work so far upstream. Any thoughts on that?
I'm going to ask Kim to talk about this because I loved when you said palliative care is a way to reduce disparities at end of life. How do you think we could move that upstream?
Thanks, Christian, for this question. This is actually an important tension, right? So we're talking here about serious illness care, and we're really looking at the outcomes of poor quality care from from disease prevention all the way through the end. And so we show up and say, well, now we'd actually like to help you now that you're almost dying. And so that doesn't feel great. I think that you're absolutely right. I really think that and I think that's why Marshall is here for many other reasons too, but that if we really want to talk about equitable care for people with serious illness, it's really hard to do that without talking about equitable care further upstream. And so that this is really a part of a continuum, a healthcare continuum, and we're continuing to improve care. Some of the things that we learned in surveying hospices in particular about this issue specifically is that they actually have thought about it, and that they really see their opening as participating in further upstream efforts. And so to get information out about care at the end of life, they talked about often participating in blood pressure screenings or other kinds of chronic disease management programs in the community where they show up and be a part of that and also provide information about equitable care at the end of life. And so I think you're absolutely right that it really has to be a part of a continuum. But don't stop helping the individual patient that you're seeing.
Yeah, I recently wrote a piece about like how can you be an advocate along different dimensions, and so clearly, you know, the core, of course, is then the caring for the patient in front of you and being an advocate for that patient. You can be within your organization, so clearly, like your organization is making decisions for better or worse in terms of the system, and so you can play your role in your organization. There's the work then with the national organizations. I actually think like a group like Palliative Care, you know, it's not like a huge group, so it's actually, you know, reasonably, you know, doable in terms of getting involved in terms of like the policy committees and work of the organization. There's the traditional things too, in terms of like speaking out, so writing commentaries, op-eds in your local paper, that kind of thing. And then there's you know, outright advocacy in terms of like, you know, politicking and all, in terms of like marching in Washington and all. So, you know, and the other one's teaching, in terms of like whether it's your colleagues, whether you have trainees, in terms of like, it makes a difference when you speak up about the issue in terms of the value. So, and it can differ too in terms of over time, which of these or combination of things is the right for you. But, you know, any of them are very great ways to get involved. Yeah.
Thank you. Yes, we have a question from the Twitterverse.
Great. Good morning. Is this working? It is working. Great. We have a question from the physician assistants in hospice and palliative medicine. And the question is, utilizing physician assistants in the workforce. These are individuals embedded in the community, working directly with those with serious illness. How can PAs help be a solution to equity? How can we grow the role of PAs in the healthcare system?
I'm going to address it as a...
Yeah, I think it's the role of others besides physicians.
Go ahead, Bridget.
Well, I just wanted to address it as patients. Patients, when they're coming in, seeing their doctors, and then their healthcare team says, well, we want you to see the physician assistants. They don't have as much faith in the physician assistant because they've built a relationship with their doctor. So at one of the healthcare systems in Seattle, which is Seattle Cancer Care Alliance, what they do is they have their either physician's assistants or nurse practitioner. Every other appointment, they're seeing them. So that way they're building a relationship with them and then building that trust. I think that's an issue where the breakdown in communication happens when all of a sudden that patient is going in to see the physician assistant and didn't know that was someone that they should be seeing, and that the healthcare system needs to build that into the visits for that individual patient that is dealing with a chronic disease.
Great point.
I think for me, there's an opportunity to speak to something that someone asked before about providers, and we're all doctors here. So first, I'm going to acknowledge that when I think of providers, I think more globally. I'm a geriatrician, so I think of the multidisciplinary and interdisciplinary team. With respect to PAs in particular, I think that certainly there's variable roles across the country. My mom lives in rural Mississippi, and almost all of the providers are nurse practitioners or PAs, and they they care for patients in the same way that doctors do. And so, I think that in terms of opportunities for providers across the board, we've identified some of those, which are really about, one is about building skill, awareness, and a passion for promoting equity. But I think the other piece is for all of us to realize that we're all members of the healthcare team and everyone has a role to play. So often I'm amazed at how doctor-centered we can be, even though I'm a doctor, but recognizing that our nurses, our PAs, our nurse practitioners, our social workers, that they actually have an important skill set for serious illness care and that we maximize the use of those people.
So I have a suggestion in terms of a parallel effort to be aware of and to look at. So 2 weeks ago, there was a new National Academy of Medicine committee that just formed on the future of nursing 2020-2030. And it's a really forward-seeking charge where the context is that there's increased emphasis upon social terms of health, on health equity, and the whole environment is changing. And so this presents an opportunity in terms of thinking about what's the role of nurses vis-a-vis underlying public health as well as individual patient care within new systems of delivery, which will probably be more team-oriented over time. And I think physicians' assistants are in the same type of situation where it's great untapped potential and it's a great opportunity with the changing environment. And so I would recommend that, like, your organization start thinking about these similar issues, and then maybe look at what this NAM committee is doing with nursing, because I think there'll be some parallel lessons that could be useful.
Thank you. Denise.
Yeah, hi. Thanks, Peggy. Denise Hess, Supportive Care Coalition. My question, I think, is for any on the panel, but primarily Dr. Machtinger. So I have great admiration for the ACE study. I think it was just so monumental and important. However, in practice of trauma-informed care, I've noticed how folks can feel even stigmatized by the results of that study because they can be interpreted in a rather fatalistic or deterministic way. And with that in mind, I've gotten more and more curious about the ACE outliers, the folks who have really high scores but defy all expectations. It was in the original epidemiological data. And along those lines, the research on resilience and growth mindset. So could you say a little bit about how I'm sure you're incorporating resilience and those properties and characteristics into your work?
Thank you very much. ACE screening is not like a typical screen where you dispassionately screen for something and then refer them for a specific treatment at this stage of our field. Doing an ACE questionnaire, either individually as a patient or with a provider, really serves to awaken that provider, that clinic, and that patient to the prevalence, the high rates of childhood traumas, and the role that trauma is likely playing in the interaction with the health system, with that provider, and in terms of responses to therapies. And so more than feeling stigmatized, actually, what I've seen is that patients feel like crack use, obesity, alcoholism, smoking, people feel very ashamed. Like you want shame, you already have shame. I think when patients can understand that their behavior is due to what has happened to them instead of what is wrong with them characterologically, they can blame themselves less, they can take a step backwards and understand, and they can understand and provider can support, like, of course you're smoking crack cocaine. Like, you've had such impossibly difficult life experiences, and this must be one way you cope. Tell me about how crack cocaine is helpful for you. Tell me about crack cocaine is causing you grief. And it can allow for a new type of conversation, a new type of compassion and patience, not only from the provider, but from the patient. I haven't felt that any of my patients have been, I mean, this is my personal experience, anecdotal, that my patients have been stigmatized by knowing their ACE score or feel like they are tracked towards death or illness. One thing about the movement of trauma-informed healthcare, it's not all about trauma and wallowing in trauma and a direct line to disease and death. There are many things that you can do to interrupt that link between trauma and outcomes. And so it's a strengths-based movement. What Rhodessa Jones does is basically takes them through those strengths-based steps. And the first is just reducing isolation. The fact that people can, most of these people who are either smoking crack or depressed, they tend to be very, very isolated. Many people haven't come out about their HIV status, their history of child abuse. And the first step towards de-isolation is very empowering. And resilience, we measure resilience in our studies. We're trying to understand, and the field is trying to understand, how that measure may be helpful for providers and patients moving forward.
Thank you. Dr. Tulsky.
Hi, James Tulsky from Dana-Farber Cancer Institute and Brigham and Women's Hospital. This idea of trauma-informed healthcare is really interesting to me. And it's new to me. And as I was thinking about sort of all the associations that you describe, what I'm trying to understand is how much of that is induced by the trauma, like the trauma is in fact a cause in some way in terms of changing how people are or behave or is toxic in some way, versus how much of this is about lack of something else. And it strikes me that there are just two different ways of understanding some of the same problems. So is it really that lack of housing, lack of food, lack of proper, resources in the community, all these other things are also going to cause all these same problems. And the reason I think it's important on that distinction, because what you showed were all these associations, and it wasn't clear to me why they're being associated with trauma as opposed to being associated with these other disparities. Because it's going to have something to do with where you're going to focus. And it's not wrong to focus on sort of healing the trauma, and yet what if the real problem is just all the lack of X, Y, and Z? So how do you tease those things apart?
Yeah, so there is an emerging field of research into the physiological impacts of toxic stress. And there's an array of physiological impacts of toxic stress on the cortisol and sympathetic nervous system, hormonal systems and nervous systems, on your hypothalamus, on your prefrontal cortex, on your amygdala, on your ventral tegmental area, which is an area that is about your pleasure response. There is now an emerging field of research in epigenetics about how all of those changes on your hormonal composition can affect the actual transcription and expression of your genes. There's many people in our movement that think it's predominantly physiological, that as a child, that toxic stress actually has physiological impacts on every system in that developing child's body. Separate from that, there are studies now, including the Urban A study, that look at poverty separate from trauma. So the Urban A study I cited statistics that were the general statistics across all poverty levels in terms of 2 and 3 times the rates of those very important outcomes from adverse community experiences. If you add poverty into that, it doubles them. So the poverty is a factor, and it makes things worse. It makes people less resilient. The protective barrier around people that allows them to be resilient and cope with some of these traumas is lessened by poverty. But the A study in general, the biggest study so far and the most famous one, it is an association study. It's not a prospective study. But these are white, working, insured individuals. 25% of the women and 16% of the men had childhood sexual abuse. And these were strongly correlated with these adult health outcomes. So my belief is that it's a combination of the two.
Thank you for that question. I think that we are set for a break right now. I can't believe we're ending right on time. Appreciate your participation and the wonderful questions that you asked. And I really want to thank all of our panel members for a terrific first session. Thank you for getting us started.